So we shall now go on to our next speaker, Dr. ANISH Madhavan, who's a specialist in cornea and cataract surgery from Dr. ANISH Madhavan's Eye Hospital at Kollam. And he has another very interesting case to show us. Lot more discussions there. On to you, Dr. ANISH.
Thank you, ma'am. And thank you, ARC and Chitra madam, for giving me this opportunity. So I'll just share my video. So good afternoon, everyone. This is an intermittent mature cataract. I'm just, as usual, I'm just poking the anterior capsule and decompressing it to reduce the intracapsular pressure. And the capsular pressure was being reduced, and I'm proceeding with a capsular rhexis with 26 gauge needle, and the rhexis was coming nicely. But many a time, the mid peripheral area will be little raised, or there will be a hump like. So if the rhexis goes onto that hump, that mid peripheral hump, the chances of a rhexis runover is more because it can extend to the periphery. So it is always better to keep it within that hump. But unfortunately, it went onto the hump, and you can see at that point of area, it went for a rhexis runover because the rhexis has gone on to that hill area, and then it went down. You can prevent it actually. If you want to prevent it, I think after decompressing, you have to just sweep the anterior surface of the lens with a dialer or make it flatter so that there won't be any hump. And here I am going for the chop. I am doing a vertical chop here, and you can see it's a little hard cataract, so I have to separate the pieces nicely to get a nice split because there will be leathery fibers will be there, so you have to make sure that these quadrants are being separated nicely. Here I'm trying to emulsify the pieces a bit in the anterior chamber itself so that I don't give much stress on the posterior capsule to prevent that rhexis runover giveaway into a posterior rent. So, but unfortunately here you can see there is a sudden surge happened, and immediately you see there is a rent. The posterior capsular rent has happened. You can see a very large rent. But luckily the piece was in the anterior chamber, so I tried to keep the piece in the anterior chamber itself, and with the help of the viscot I plugged the rent area and tried to emulsify the piece, and I made sure that the piece should always be in the tip. I never allowed the pieces to move away from the tip. So I just made a small chop and tried to emulsify it. I didn't make big pieces. If I make two separate pieces, definitely the chances of drop is more. So I try to emulsify the whole piece as such, but I never allowed the piece to move away from my tip. My phaco power was less, but my vacuum was high. So now I remove all the pieces. Luckily the vitreous was not disturbed, so with the help of viscot the vitreous was nicely pushed down, and I just cleared the cortex. You can see that trend nicely, and then I placed a 3-piece IOL in the sulcus, and I try to keep the haptic away from the rhexis runover area, and it was kept in the sulcus, and the case was finished. Thank you.
Thank you very much, Dr. Anish. Lot of pearls came out of this presentation. It is just that I would have preferred to, if a small rhexis had been created, and then you had increased it later on to avoid that extension, because the rhexis was started off a little large, that happened, and the decompression is sometimes not adequate, even though we think we have adequately done it. And of course, these are the ideal cases for doing an IOL scaffold too. You manage it very well. the way you did a bit of an anterior chamber phaco so that that area of extension does not go further, wrap around, and you did it very well. You managed it very well. But in any other hand, there could be a possibility of those fragments going in through that area. The PCR was already there, no? So you could have slipped in and a 3-piece IOL and then gone ahead and removed the fragment and done a vitrectomy, and then, was ensured that the haptics were placed away from the area of weakness. Dr. Mohan, you have anything to add here?
No, I would have done, I think it is beautiful video, very well managed by ANISH,
Yes.
but I would have done certain things differently. One is when I have a hypermature intermittent cataract, I always do the rexis with the Utrata forceps, either a micro rexis forceps. I would not do with the needle because you would have less control with the needle and you will not be able to control it. And that's what has happened, number one. Number two is when you lost the rexis, immediately what you should have done is you should have tried this little rescue technique wherein you flatten the capsule and pull it in the same direction. You pull it in the same direction, then probably you could have retrieved the rexis and prevented the loss. Third thing is I would have chopped and made the chop smaller into this thing, because what you try to do is you try to chop and try to bring that entire nucleus up. Yes, I would definitely do an iris plane or anterior chamber phaco, but I would have chopped it in the bag and then brought it up. Okay, what you did was the other way around. You chopped it, but you brought the entire nucleus up. So what happened was there was a traction on the weak area which extended back. Okay, once this thing is there, then always I put tricot to find out whether vitreous is there. Even at the end of the surgery, I think you should have used tricot to find out whether vitreous. Even the people who small, the round and the thing, you didn't see any vitreous, but I would have put tricot there. And IOL scaffold also, you can do that, provided you take care of the vitreous first. Take care of the vitreous, put an IOL scaffold, and then take care of the nucleus.
No, you could place an IOL scaffold, take care of the nuclear fragment, and do vitrectomy in front of the IOL, and then go back behind the IOL and do a vitrectomy too.
And also bimanual IA. Once you see a PCR, no coaxial, bimanual, separate the irrigation from the aspiration.
Yes. And Dr. Rohit, do you have anything to tell about the direction of chopping in the case of a rexis tear?
Yeah, it has to be in the direction, not away from it, not 90 degrees from it, because that would put more stress on the make the tear go and become a wraparound tear. And when he was trying to bring those things forward, they were not separated, as Dr. Mohan said. Since they were not fully separated, and in trying to doing the maneuver in the plane in which the nuclear pieces were, those were putting more stress and made the tear a wraparound tear. IOL scaffold is definitely the answer. Another great thing which I have been doing lately, which I've realized is a big help, is a low IOP phaco. And I'm using around 28 millimeters of mercury at 20. And even if you have a posterior capsular rent, the nucleus doesn't fall behind. That is another beauty which I have realized. I've seen at times, when you just try it, everybody should try it. You just try to raise the bottle height and see how much fluid is going in. When you reduce the bottle height, the amount of fluid which is coming out of the phaco handpiece is very little. So when you are doing a low IOP phaco, even if it is extended and you're not sure whether it is pre-equatorial or post-equatorial, you cannot undermine the importance or belittle the importance of low IOP phaco. So low IOP phaco is something which should be adopted as a prerequisite when you are in such a situation.
Yes, and should the lateral separation of the fragments be avoided in the presence of a tear?
It should not be much. The lateral separational forces should be minimal. Either be out or be in, and the flap motility sign, the flaps were motile till some point. And suddenly when you were doing it, they stopped being motile, and that was the end point of safe phacoemulsification, and you should have converted. That is another point. But in very hard cataracts, if you can, you should try to bring it forward. You can do all these, use the flap motility sign, when the nuclear fragments are maybe till grade 3 or so. With grade 4, grade 5, with so much of increased anterior posterior diameter, you have to be wary of, that the flap motility sign will eventually become a post equatorial wraparound here. So hard nuclear fragment, if it is there in such a situation, if you can do it supracapsular or convert. Dr. Mohan, would you like to add something to it?
Yeah, absolutely. I think I fully agree with you because the flap motility design is something which is very important. See, for him, the tear was on the right side. My entire manipulation would have been on the left, completely on the left, never on the right, never near the tear, always on the left. So it makes your life easy because we are all right-handed surgeons. We are all used to the chopping on the left side. So left side, you brought the thing to the left. Make sure there's complete separation before they brought the nucleus up. That's all, I think. Yeah.
The site of incision is also very important. It should not be in the in the plane of the extension. If possible, if you can have it at some angle, that also helps. Because if it is in the plane, the site of incision and the rexus tear, if they are parallel to each other, that predisposes more to a flap becoming the anterior capsular tear becoming a wraparound tear.
Dr. Ramurthy, you want to add anything? Dr. Kapil, before we go on?
Most points have been covered, but just to prevent the problem which happened, of course, all of us know it. He very nicely described the hump where the rexus tends to run off. Sometimes even when you're proceeding with half the rexus, you find there is an area of cortex which is bulging forward. Even at that step, you can go ahead and aspirate a certain amount of cortex over there, or introduce a certain high viscosity viscoelastic, something heal on in that place just to flatten it out so that the rexus is very often what happens is it's going quite smoothly. We have covered 270 degrees. You get very confident. You think it's almost going to finish off. And then that's the time when you have a runoff. So you have to be cognizant of the fact that rexus runoff can happen at any time. And especially though Mohan mentioned it, I do all these cases with a bent needle only. And it works quite well with me because whenever I go in with the Utrata needle, Utrata forceps, I find that there is a tendency for the AC to shallow.
Yes.
Whatever be your preferred instrument, it's a good idea to keep the anterior capsule flat right through the stages. And as was mentioned, in these cases, phaco chop is a good idea, but I would have gone ahead and split the nucleus into two. And with the separation happening away from the area where the rexus runoff was there, and subsequently brought each of the fragments into the anterior chamber, and with using adequate dispersive viscoelastic, gone ahead and done a gentle phacoemulsification. And I think this is an ideal situation for doing the AIOS scaffold, where the anterior vitreous phase is still intact, and there's just a couple of nucleus fragments, and you have a rexus, enough rexus to support the three-piece lens also. And you nicely tamponaded the anterior vitreous phase with a dispersive viscoelastic, and then you could have gone ahead and managed this case. But well, ultimately, whatever you did, it worked out very well in your hands, and that's what matters.
Brilliant. Yes.
You had pointed one point, which that you create a small rexus. That is a very important point, which you said. And after that, you should do what Chi Soon Paik does. He does the capsular milking. When you do needle decompression in the center, the central area is concave, whereas the mid periphery is still has still lot of cortex in it. So you have to milk it towards the.
Yes.
So that is another point which should be.
Yes, yes. I'm very glad with the kind of videos which are saying, one, the surgeons are of great caliber, but also there is so much of discussion point which is coming forward. And I think it's not just you all of us are learning from each of these videos, and thanks a lot